Welcome back everybody, David here again with Med School Bootcamp. So now we're going to talk about another pretty commonly tested nephrotic syndrome called focal segmental glomerular sclerosis, sometimes shortened to FSGS. So the pathophysiology is going to include a lot of the kind of general concepts we talked about with nephrotic syndromes, in that there's damage to the glomerular filtration barrier. But one of the unique things about this condition is that you get sclerosis of the glomeruli. This is particularly important when we move down to our diagnosis section, and you can see that when we're looking at light microscopy, we're seeing something called segmental sclerosis and hyalinosis. This is a really important histologic finding that they will expect you to kind of recognize. If they were to give you an image in a history of a patient, they would expect you to recognize that if you look at this glomerulus over here, you can see that there's kind of a differentiation where I'm drawing my highlighted green line. Over here, it's very sclerotic, it's very dense and dark pink. Versus over here is a little bit more white, a little bit more of a typical glomeruli structure that we would see. Remember on the last video about minimal change disease, I showed you a fairly normal light microscopy of a glomeruli. And in that video, the glomeruli mostly just looked like this section right here, where it's a little white, a little more spaced out. But you notice on this glomeruli, if I remove the green highlights, look how much darker that pink is compared to the other side of the image. So the green highlight shows a much darker pink area, which is indicative of sclerosis. The next important diagnostic tool is the electron microscopy. Again, this is showing podocyte effacement. So you can see over here that this outer portion of the membrane does not have big, tall structures such as typical podocytes that might look something like this. Instead, we're getting more flat structures that look sort of like this. So we call these flattened structures, or we say this is podocyte effacement on electron microscopy. Finally, we're introducing a little bit of a newer histologic thing called IF, or immunofluorescence. Because this is not an immune complex mediated condition, we typically will not see, or will typically have negative immunofluorescence in this condition. We'll contrast this with an upcoming nephrotic syndrome, which is immune complex mediated, and thus we would have a positive immunofluorescence. However, as with many things in medicine, it's not as easy and straightforward. While typically it's a negative for immunofluorescence, there are times where you can possibly get positivity for C1, C3, or IgM immunofluorescence. And so while it's helpful to be aware that this is a possible thing, it's fairly unlikely that they would test you on. This is a little bit of a nuanced portion of focal segmental glomerular sclerosis. So really, I think the highest yield one to know is going to be the light microscopy. I'll draw a big star by it because they really want you to notice that if you look at a glomeruli, if half of it's sclerotic or it's dark pink versus the other half, which is more of a normal appearance, a little more white, a little more spaced out, they want you to be able to notice that on pathology. So I would say that's the high yield image to know here. Next, let's talk about the management of FSGS. So remember minimal change disease, I said that we can use prednisone and it has a good response. However, this is in contrast to FSGS, which can also be treated with prednisone, but the response is typically poor. That is to say, even though this is a treatment option, patients don't necessarily respond as well as maybe a patient with minimal change disease. You can also consider some other things such as immunosuppressants and even anti-inflammatories, but it's less likely that they would ask you for treatment or management options for these conditions because there really is no clear answer, because it's a little bit complex and it really takes a higher level of understanding of the renal system and the patient to really make these decisions in terms of what the options are. So really, I think the point that I want you to take from this is that there are options to help with these patients, but there's not necessarily a clear-cut winner in terms of, yes, this is definitely the right treatment option for this given patient. And thus, because of that, it makes for a less commonly tested concept. What you can do with these patients is work on symptomatic management. Remember, this is a nephrotic syndrome. So what are the kind of patient symptoms that you might see on physical exam? Remember, they might have edema and they might be experiencing other pathophysiologic changes that we have associated with nephrotic syndromes. And so we can work to symptomatically manage those portions of the patient's condition. And finally, it's important to note that FSGS often progresses to chronic renal failure if untreated. So what this is saying is that while there's no clear-cut definitive treatment option, we should be doing what we can. We should be offering some things to try and help the patient so we can at least limit the chance that they develop renal failure in the future. And finally, to wrap up this video, I want to talk about some important associations. It's important to know that FSGS is often idiopathic, and what that means is that there's no readily identifiable cause for the condition. It can just happen. However, they're more likely to test you on association of a secondary cause of FSGS. Some of the ones they really want you to know include congenital malformations, that there's a higher prevalence in African American and Hispanic populations, that it can be associated with heroin use, and it can also be associated with patients who have a diagnosis of HIV. I put a high yield by this one simply from an experience perspective. I've seen that this is one of the more commonly tested associations, so much so that it's important to have a way to make this association with a patient. And the way to do this is just to remember a little rhyme in your head that says FSG, HIV. FSG, HIV. And this is purely used as a memory aid because commonly test writers will ask about this association in a patient who presents with either a known condition of HIV or they're presenting with labs that is indicative of having an HIV infection. And then they're talking about some kidney problems and some dysfunction. And they're trying to help you with that correlation of an HIV patient potentially having a diagnosis of FSGS, or FSG for short. And finally, some other associations that can be tested as well include patients who are taking interferon treatment or sickle cell disease. So the overarching principle here with all these different associations and all these conditions that can lead to FSGS is that the body is being exposed to a stressor or a toxin that is damaging the kidney and leading to focal segmental glomerular sclerosis. And so again, our overarching point with these conditions is that something that damages the glomerular basement membrane or the filtration barrier and ultimately affects our ability to monitor what we're filtering at the level of the kidney can cause downstream effects. It can cause continued damage to the glomerulus, and this can lead to losing certain molecules in our urine, such as our albumin, our antithrombin, and ultimately be problematic for the patient long term.